So if we fill up from the front. We just wait for everybody to snuck off for coffee to come in. Okay, yeah.
I think he's got
All the talks are available online if you go to the AER website. So if you want to do anything next door, catch up on anything, or get a reference, they're all available online.
but not while we're talking.
They are being beamed around the world live at the moment. We get ahead of you. Yes, so we'll have a lunch after this, so we'll have another session here, and then there's a draw session right at the end, and then we'll again.
Thank you very much, and welcome to our next session. I'm very pleased to welcome my colleague Joe DeBono, who's had the awesome task of organising this and has done an amazing job. And he's going to talk to us about anticoagulation and NOACs, first amongst equals. Thank you very much, Joe.
So it's a real pleasure to be here, and one of the real aims of this was to try and bring together everybody from the nurse specialist to the general cardiologist to the super specialist cardiologist in their ivory towers. And I'm going to talk about NOACs. I still call them NOACs. I know they became DOACs and all sorts of other things, but I tend to regard them as non-vitamin K oral anticoagulants, and I can remember NOAC. And I think it's made life an awful lot harder. It used to be really easy when you started. When I started as a cardiologist nearly 20 years ago, there was Warfarin. We didn't use it enough, and if your hair fell out on Warfarin, you could give them Synthroid. And it was a troublesome medicine, but that was really the anticoagulation's problem and the patient's problem. And perhaps we weren't really aware of how bad we were at using Warfarin. Now, however, I think everything's really, really complicated. And the great marketing push for the NOACs is that they're very easy to use. And for your average patient, they are very easy to use, and there's probably not that much difference. But it's important to remember the NOACs aren't all the same. We all know atrial fibrillation causes strokes. We have fantastic evidence that if you have an ECG of a patient and it shows atrial fibrillation and they have risk factors, we can make them live longer and reduce their stroke incidence by giving anticoagulants. We have Warfarin, we have other variants. We don't tend to use them very much in this country, but Synthroid I use occasionally. It's quite useful, as I say, if people have problems with hair loss on Warfarin. But they're very similar to Warfarin and they require blood tests. But there are disadvantages. There's no set dose, you need regular blood tests, you're aiming for a target INR, there's a lot of interactions with food and drugs, and some people are just genetically predisposed to having poor INR control. Some people have poor INR control because they lead chaotic lifestyles. Other people really try, and they're really religious about having their blood samples and taking the dose prescribed, and still their INR wavers all over the place. And the really worrying thing about Warfarin is that unless you have really good Warfarin control, you're actually better off taking nothing. Unless your time and treatment range is about 60% or greater, you're worse off on Warfarin than taking nothing. But the corollary of that is if you have a patient who has fantastic INR control, and we all have those, and I still keep them on Warfarin. If their TTR 70-80%, their INR is always 2.5, well, they have a really good outcome from Warfarin. And one of the problems with the trials is that the TTRs were all right, they weren't brilliant, they were on the sort of range of sort of 60s and low 70s, but that includes some patients with awful control and some patients with fantastic control. I think if you look at the data from Korea and Taiwan, there was appalling TTR, so they're never going to do well with Warfarin. Sweden, for example, has the best INR control in the world, and very few of the studies were solely based in Sweden, possibly for that reason. So what about the new anticoagulants, the non-vitamin K anticoagulants? There are 4, there's actually 5 now. There's a new one called Patrixaban. I don't use it, it's not widely available, it's not in this country, but that will no doubt be coming through. We have Dabigatran, which is a direct thrombin inhibitor, and the others are factor Xa inhibitors. They do have advantages. I've put in bold that the perceived advantages, and they're not entirely true. You don't need as many blood tests as Warfarin, but you do still need regular blood tests to check your renal function. Once you're over 75, the guidelines are probably at least checking the renal function twice a year. Again, even more frequently once the creatinine clearance starts to deteriorate. Fewer drug interactions. Well, that's probably not true. The great thing about Warfarin is you know when you've got a drug interaction because the INR goes all over the place. With the NOACs we'll come on to, there are some really complex drug interactions that cause a lot of problems, but you have to know about them. However, even though I like Warfarin, I would take a NOAC unless I was a special patient. I think they are probably safer. I think they definitely have a lower risk of intracranial hemorrhage, and if you put them in a meta-analysis altogether, they have a lower mortality, certainly in patients who have reasonable TTR control. But remember, you can't use them in people with metal valves or if you've got significant mitral stenosis. The metal valve thing is really interesting. There are some trials at the moment looking at rivaroxaban as a BD drug for mitral valves, particularly in countries that have real problems with measuring warfarin and INR control. So it may be in the future that the NOACs do become licensed for metallic valves, but it will be at a much higher dose and a different dosing regime. So be very careful about that. Why does warfarin cause more intracranial bleeding? It's probably a specific effect of the warfarin because it acts on factor 7. Now factor 7 has a particular role in controlling bleeding in the brain, and the other drugs don't act on it. So there's probably a very direct pharmacological reason why the vitamin K antagonists have a higher risk of intracranial bleeding. So what are the choices? I don't expect you to read this table. This is a table from the ERA Practical Guide on NOACs. And if you're really interested, I would suggest reading it. It's a fascinating document, although at the end you're more confused than when you started. These are the 4 drugs: dabigatran, apixaban, edoxaban, rivaroxaban. And the first thing to note is their characteristics are incredibly different. So dabigatran is 20% non-renal secretion, whereas rivaroxaban is 65% non-renal secretion, and apixaban is 73% non-renal excretion. They're all metabolized differently in the liver. Rivaroxaban, you have to take with food. Interestingly, edoxaban is also absorbed better with food, but it doesn't seem to make any difference to the effect of edoxaban in the trials. So rivaroxaban, you must advise and document that you've advised the patient to take with food. Edoxaban, you don't. The really fascinating thing about the NOACs, edoxaban and rivaroxaban are once daily NOACs, and apixaban and dabigatran are twice daily NOACs, but which NOAC has the longest half-life? It's dabigatran. If you look at rivaroxaban in a young patient, its elimination half-time is 5 to 9 hours. It's probably only active for 12 to 14 hours, yet it works really well in atrial fibrillation. But that's probably why it doesn't work in patients with metallic valves. And that can be really useful, but also just makes you think that perhaps to prevent strokes and atrial fibrillation, you don't need 24/7 anticoagulation, you just need a good bit of anticoagulation each day. And that fits with what we do when we cardiovert a patient. If a patient has AF for less than 24 to 48 hours, we're quite happy to anticoagulate them if they've not been, to cardiovert them if they've not been anticoagulated. Whereas if it's longer than that, it's time for the clots to build up. But that's quite an important thing to think about, that the reason they're BD or once-a-day drugs is because of how the drug companies design them and design the trials, but actually if you look at half-life, it's not entirely logical. I'll go through them all individually. So a few specific things. Dabigatran, they're quite big tablets and you can't crush them. And they come in their own little blister, you can't take them out and put them in another blister pack. And that's quite important for some patients. If you've had a gastrectomy, significant dyspepsia or have ulcers, there's some evidence dabigatran is not as effective, so you might not want to use them. However, the really good thing about dabigatran is it's the only NOAC where we have really good data for the lower dose. So dabigatran 110 milligrams is as good as warfarin. For all the other drugs lower dose, we either don't know or it's slightly worse than warfarin. So it's perfectly reasonable to use a low dose dabigatran, particularly in a patient at a higher risk of bleeding. This is a key trial. I've used the same colour scheme for all of them, where the drug makes a significant difference that's beneficial. You've got a red figures. Where it makes a significant difference that's bad, it's white. And one thing to be wary of is that most of the NOACs increase your risk of bleeding, particularly in the gastrointestinal tract. It depends how you measure bleeding and how you define serious bleeding. For most patients, GI bleeding is not a big problem. You can replace the blood, you can treat the ulcer. It's not usually life-threatening. Intracranial bleeds are almost always severely disabling and life-threatening. And so all the NOACs reduce the risk of intracranial bleeding. So dabigatran at the higher dose increases your risk of GI bleeding, whereas at the lower dose reduces your risk of intracranial hemorrhage, but is just as effective as warfarin in preventing a stroke. Rivaroxaban, I've put the banana up here. It's amazing how many patients don't know you have to take it with food. It does increase your risk of GI bleeding, but you can crush the tablets. We don't have as much data for the low dose regime, but people use it quite a lot. And again, this is the Rocket AF trial. Lower risk of fatal bleeding, lower risk of intracranial bleeding, same stroke rate. Apixaban, either a 5 milligram or a 2.5 milligram tablet. It's a twice daily tablet. You can crush the tablets. It's available in liquid form. We don't have prospective data for the low dose, but we have got really good data for apixaban and renal failure, and as we'll come on to, we've probably got the best trial in acute coronary artery disease with apixaban. This is the Aristotle trial. It did not show an increase in GI bleeding in apixaban. So if you have a patient at higher risk of GI bleeding, apixaban is one of the drugs I consider, or low-dose dabigatran. And it again reduced the risk of intracranial hemorrhage. Edoxaban is the latest one on the market. It's still quite established. The main trial came out nearly 6 years ago. You don't need to take it with food, and it is a once-daily tablet. There is a lower dose regime, but the lower dose regime is associated with a higher stroke rate than warfarin, but interestingly a lower overall mortality. So it's very reasonable to prescribe it for a patient, particularly if you're worried about their GI bleeding. The Edoxaban trial was much bigger, hence everything's black and significant because they just had much bigger numbers, and they were able to select their patients better to put into the trial to get the right results. So in summary, they all are fairly effective. They're as good or possibly better than warfarin at preventing ischemic strokes. Most of them, but not all of them, increase your risk of GI bleeding, but the risk of intracranial bleeding or life-threatening bleeding is much lower with the NOACs. Let's go back to interactions. We all know about interactions with warfarin. Amiodarone, nightmare. If you start someone on warfarin on amiodarone, they'll almost certainly have to reduce their dose by a third. Mangoes, if they suddenly go and have a mango fest, that will affect their warfarin. If they have tuberculosis and you give them rifampicin, well, you can forget about using warfarin to anticoagulate them because it's almost impossible. You can monitor the INR closely, you can warn the patient, and in motivated patients, particularly ones who can self-monitor or have excellent GP practices or haematology services, we can manage this interaction really well. There is an interaction, but we can cope with it because we know about it and we can measure it. The DOACs, NOACs are more difficult. There are multiple drug interactions. They're poorly understood. Most cardiologists haven't got a clue. Most electrophysiologists don't really know. We don't routinely measure blood levels. There is an argument you get better protection against strokes and reduced bleeding if you did measure the 10A levels or the blood levels of these drugs. But the companies aren't keen on that because, of course, that takes away the big advantage of using the NOACs or the DOACs. And there are very complex guidelines, and I'll try and summarise those in an easy form. There's also metabolism. They have different uptake, so rivaroxaban is much better taken up with food. Dabigatran is an interesting drug. Hardly any of the active drug gets into the bloodstream. Whereas apixaban, 50% does, and rivaroxaban with food, more than 80% of the drug is absorbed. They're all metabolized by the liver, and there's a lot of interactions at the level of the P-glycoprotein and cytochrome P450, which is the main reason for problems, either upregulation or downregulation. And the ERA produces these very good guidelines, and they're in that ERA document I mentioned. Basically, if you get a red blob, you shouldn't be using the drug. If you get an orange blob, you should be thinking about reducing the dose to the lower dose, and if you get 2 yellows, then that's the same as an orange or possibly a red. So it's a good guideline. This is just looking at the 4 drugs against the common cardiac drugs, the ones I use. So amiodarone has an effect on all of them. That makes it a bit difficult. If I have a 79-year-old patient who's 60 kilograms, does that mean I reduce the dose? You have to think about it a lot more. Dronedarone, thank goodness that drug we don't use very much anymore, because that was a complete nightmare with the NOACs. But even verapamil can have a significant effect. So you just need to think about it with cardiac drugs. Most of those are going to be on the recommendation of an electrophysiologist or a cardiologist. Other cardiac drugs, atorvastatin and ticagrelor, no evidence at the moment of any major interactions. Clarithromycin and erythromycin are also quite interesting. If your patient's going to have a long course of either one of those, that can have a significant effect, particularly on edoxaban, and you may want to reduce the dose. Again, rifampicin, complete nightmare. As soon as we have patients on rifampicin, we talk to our haematologists and we think about low molecular weight heparin and whether the risk outweighs the benefit while they're on the rifampicin. And the other group that's really difficult to manage is your HIV drugs. So if you have a patient with long-standing HIV and we're having an increasing number of these, they're incredibly well and they get atrial fibrillation. But knowing which NOAC to put them on is a really difficult decision. So if I have a patient on a particular protease inhibitors, I send them to my haematologists and we discuss them with our HIV service as to how we're going to anticoagulate them. And I think that's going to become a bigger problem in the future. Other drugs, old age, low weight, poor renal function can all have an interaction, and I'd suggest that have a couple of NOACs that you know really well, and then if you worry, start to seek help. But that's not all. Anti-epileptics are difficult. Antifungals, really difficult interactions. And then cancer. When I started at medical school, once a patient had significant cancer, it wasn't really a problem for the electrophysiologist or cardiologist. But many of these patients are living for years and years and years. And these new biological agents for treating melanoma or CLL are a real nightmare with the anticoagulant drugs that we're using with the NOACs. They're a massive interaction. Some of them actually significantly increase the risk of atrial fibrillation. So it's a real problem managing these patients. And again, once patients start being on complex anti-cancer drugs, I tend to involve the multidisciplinary team because it gets really difficult. In the good old days of Warfarin, you just measured the INR. With these, it's more difficult, and usually they require measuring of levels. Sometimes the oncologist will want them on low molecular weight heparin anyway, rather than the NOAC while they're having their therapy. And we can work together to try and work out what the best answer is. We will learn, but it's going to take a few years. And we're seeing an increasing number of these patients. And increasingly they're doing so well, they're now coming to us for ablation. People who used to have metastatic melanoma, they're fine 2 or 3 years later, but have bad paroxysmal AF. So we have to anticoagulate them, and we work with our oncologists. So my advice on interactions is for the vast majority of patients, they're not a problem. Most of the antiarrhythmic drugs, the diltiazem, verapamil, amiodarone, on their own are okay. It's only when you start having 2 or 3 or 4 of them it gets more complicated. But be careful in multiple drugs, be careful with the cancer treatments, the epileptics, and any kind of antimicrobial drugs. And particularly in the older patients, the lighter patients, and the renal failure patients. We'll come back to renal failure later because it's another very difficult area. What about reversal? One of the things I say to patients is, oh, they don't want to go on the NOAC because you can't reverse it. Warfarin's lovely. You can reverse warfarin very quickly with Beriplex. It's very expensive. It is made from blood, so that can be a problem if you have a Jehovah's Witness who might not want to be treated with Beriplex, and we'll come back to them later. What about the NOACs? Well, the first agent we had a reversal agent is dabigatran, and it's a monoclonal antibody fragment. It mops up dabigatran very quickly. It's hideously expensive, but most of the major trusts, big trauma centres and big hospitals now stock it. So that's available. We can reverse dabigatran very quickly and very effectively. The rivaroxaban and apixaban are more difficult. There's a new drug out called adenexate alpha. Now what this is they've reconstructed the factor 10A in a sort of recombinant form that's inactive, and what that does is mop up all the rivaroxaban or apixaban. It's been approved by the FDA. There isn't any trial evidence, but there's some prospective studies of case series, basically, looking at these patients. It seems to work in patients with rivaroxaban and apixaban. We don't know about edoxaban yet. Theoretically, it should work, because edoxaban should be able to bind to this receptor, because it's a generic, any drug that binds to factor 10, but we don't know that yet. It's also hideously expensive, tens of thousands of pounds, and it's not widely available yet in the United Kingdom, but probably will be over the next few years. So we can probably reverse all of them now if we have to. So edoxaban we're not sure about, but theoretically should be able to be blocked by adenexate alpha. But we come on to more specific patients. Increasingly we're anticoagulating younger patients. You might have a 35-year-old with hypertension or diabetes who's female and has atrial fibrillation. They've got a chance of a score of 2. They need to be anticoagulated. But the NOAC significantly increased abnormal uterine bleeding. Interestingly, Warfarin doesn't. Some people manage this by stopping their anticoagulant just when they're having their period and starting it again. That makes them a little anxious, because if you're stopping it for 5 days, just at the time when your body is bleeding and so having a reaction to bleeding, that will increase your risk. And another option is to switch them to Warfarin. It might sound very old-fashioned, but the vitamin K antagonists cause far less dysfunctional uterine bleeding than the NOAC. And we also see that in some of our congenital patients where we use the NOACs. If you're on rivaroxaban, you're twice as likely to need some form of intervention for your abnormal uterine bleeding, and at least a quarter to a third of patients on the NOAC will have increased abnormal uterine bleeding. What about acute coronary artery disease? Every time our interventionalists present at a grand round, they present one of these studies. So in the old days, you have a heart attack, you start on aspirin and clopidogrel, and then what do you do if they have atrial fibrillation as well? We were putting people on triple therapies, aspirin, clopidogrel and warfarin. So the evidence base for that was quite poor. There's quite good evidence for warfarin plus aspirin or warfarin plus clopidogrel, but the companies have put a lot of effort into seeing what we can do with this patient population. I don't want you to go through them in individual details, but there's 3 big trials for rivaroxaban, dabigatran and apixaban, comparing using the NOAC basically in place of warfarin and in place of aspirin. So they tend to go on dual therapy for a year and then just on their NOAC. And there's good data that it's at least as effective with a much lower bleeding rate than triple therapy. The rivaroxaban and dabigatran trials were a little unfair because they compared NOAC plus clopidogrel against triple therapy with warfarin. The best trial, I think, is for the apixaban, which is the Augustus trial. It's probably the best trial because it was the last trial to be published, so you could design it on the basis of the criticisms of the others. But that was a very good trial comparing apixaban versus warfarin and aspirin versus placebo in a sort of two-way trial. And that very clearly showed that if you just were on apixaban and your either clopidogrel or ticagrelor or whatever your other antiplatelet was, that was enough. And you didn't need to go on aspirin as well. So dual therapy for most people following a stent. And most of our interventional cardiologists are doing this now. If you've got a patient at very high risk of bleeding, you might reduce that further, or you might even avoid giving them anticoagulant while they're requiring aspirin and clopidogrel. If you've got a lower risk patient with a very high risk stent, my interventionists always worry when they put a stent in the left main that they don't want me to mess up their stent by changing the anticoagulant. Then you might give them dual or triple therapy a little bit longer. But the data is now coming out to suggest that a NOAC plus a platelet inhibitor on its own is enough. What about stable coronary disease? Well, this is a very good trial comparing just rivaroxaban against a combination of rivaroxaban and aspirin. And it showed no benefit in terms of as a combination, but an increased risk of bleeding on combination therapy. And I think this is a really important point. We still hammer this home with our interventionists. Sometimes you have to quote the guidelines to them to make them think about it. But almost no patient should be on aspirin or a clopidogrel or another antiplatelet agent and a NOAC once it's more than a year after their myocardial infarction, unless they're a special patient and that decision has been made actively. The vast majority of people are still on it passively. Nobody stopped the aspirin, nobody stopped the clopidogrel. What you need to do is say, should this patient be on dual therapy, or are they good enough just to be on a NOAC on its own? And certainly for rivaroxaban, I'm looking at the data, it's very likely to be the same for apixaban, dabigatran, and edoxaban. They shouldn't really be on dual therapy unless there's a particular reason. Either they had a really difficult stent that isn't fully deployed, or they've already had a further event on a NOAC, or they may have had a stroke despite being on a NOAC. There are very subtle reasons why you might, but you always need to think about it and think, why is this patient on both therapy? It's more than a year since their heart attack. Obesity. We've heard this morning how obesity increases your risk of atrial fibrillation. If you look at the licenses for the NOACs, they're only really licensed up to 120 kilograms or a BMI of 40. In fact, they probably are safer in larger patients. For a long period of time, what we were doing is measuring levels or activity of the drugs in high patients, but you have to be a little bit careful in the very obese patients. Once they get to sort of 150 kilograms, I start to be a little bit cautious and talk to my haematologist. And they can often measure your levels and say that's working well. But the best data we have is for apixaban. This was a sub-analysis of their big trial. And it's important to note they have 15,000 patients with a weight between 60 and 120 kilograms, but only 248 patients weighing above 140 kilograms. So we don't have that data. It's always struck me as a little bit odd that a 60 kilogram person and a 180 kilogram person should have the same dose of drug. But on the other hand, the data from this trial seems to show that over a wide weight range, there is benefit to apixaban. It's at least as good as warfarin. Interestingly, if you look at major bleeding, the time when you get the most benefit from apixaban is when your weight's between about 60 and 80 kilograms. This is the bottom graph on this side. But actually, apixaban does seem to work over a wider weight range. So we're getting a bit more relaxed about using it in the heavier patients. Renal impairment. This is another really difficult area of the NOAC. With warfarin, you can measure the INR. All the drugs have their own different guidelines for renal impairment. This is taken from the AER guidelines. A couple of things to note. The little yellow arrows with edoxaban, when you've got a GFR, a creatinine clearance greater than 95 mL a minute. There's some data from the trial. If you've got supernormal kidney function, edoxaban isn't as good as warfarin. Now that's particularly an issue for us if we're taking young patients for an ablation. Whether that's of any clinical significance, I'm not entirely sure, but certainly I get a bit cautious giving edoxaban in people with very, very good renal function. Of all the NOACs, Apixaban is probably the easiest to use, down to about 30 mils a minute, and then below that you need to adjust the dose and be quite careful with the dose. Once a patient's on dialysis, things get very complicated. Actually, the evidence that anticoagulation works in dialysis patients for reducing stroke and improving mortality is quite low. They have a very high risk of bleeding, a very high risk of stroke, and a very high risk of cardiac disease. Some trials show no benefit of anticoagulation in dialysis patients, others do show a benefit. The two agents that are most widely used, Warfarin is quite widely used, and the Americans have started to use apixaban. There's quite good data out recently that using full dose apixaban on dialysis seems to work. It's not in the license, but it's something that the Americans are doing, and there's some data from it this year. But that's something I always liaise with my nephrologist about, and think about the bleeding risk versus the stroke risk. And this is just a summary. They all work if it's mild to moderate. As the renal function goes down, watch it more closely. And all the trials excluded patients with a creatinine clearance below 30. So we're hypothesising they work below there. We don't know it. We think they probably do, but again, it's hypothesis. There aren't going to be any trials because nobody wants a negative trial, but we think it's going to work. Nasogastric tubes, we're nearly finished. You can't use dabigatran, you can crush them, or you can use liquid apixaban. This is quite relevant in patients who've had a stroke and had AF and you want to anticoagulate them longer term. And then we come to the special situations. This is me skiing, typical middle-aged man. I see quite a lot of patients now with AF who want to go skiing. But when you ski, you have a risk of falling and hurting yourself. I advise them to wear a helmet, but also in these patients there's a theoretical argument for using one of the once-a-day preparations. If you remember at the beginning, rivaroxaban only has a half-life of 9 or most 14, 15 hours. So if you take the rivaroxaban at the end of your day skiing, when you come back to the hotel for a cake, when you're skiing the next day, particularly at the end of the day when you're most likely to fall because you're tired, actually you won't have any anticoagulant in your blood at that point. There's no trial evidence for that, and it probably applies to other sports with a high risk of injury. The other group are Jehovah's Witnesses. We have a small number of these patients, and the Jehovah's Witnesses, they don't want to have blood transfusions, and they also don't want to be treated with products derived from blood. For most patients, having a big GI bleed is not a problem. If you have a GI bleed, we give you blood, we sort it out, and the NOACs wear off very quickly. But if you're a Jehovah's Witness, we can't give you blood. So actually, the consequences of a GI bleed are much greater. So for those patients, I like to use an agent where we have the lowest risk of GI bleeding, so either dabigatran or apixaban. I particularly like dabigatran because it does nowadays have the low dose dabigatran does have a reversal agent that's more widely available. As Nexate alpha becomes more available, there'll be more of an argument for using apixaban. And it's a non-human derived, they're all recombinant, so that's not a problem for the Jehovah's Witnesses. But when you concern them for your nerve, you have to have that discussion with them and explain to them. So in summary, I do believe in the NOACs. I think for the majority of patients, they're better than vitamin K antagonists. They are all slightly different. And for your 60-year-old with hypertension or diabetes and good renal function, it probably doesn't matter which one you're on. And you get used to one that works well for you and you understand. But some NOACs are better for some patients. And you just have to find the ones that work for you. Once they start being on complex drug regimes, it gets difficult. Once the kidneys start working, it's difficult. NOACs are not the best drugs for people who are at high risk of GI bleeding. You know, Warfarin is another good choice for people with a high risk of GI bleeding. And you have to think, there's some debate particularly about dabigatran causing more lower GI than upper GI bleeding because more of it gets through to the bowel. There are some subtle things, and I'd suggest at that point it's worth seeking a haematologist's advice. Very fat people be cautious about, and women of reproductive age, talk to them about whether they might prefer to be on warfarin because it might mean they have less menstrual bleeding problems, or alternatively refer them or sort them out so that you can suppress their periods and it's no longer an issue for them. Of course, none of the NOACs are licensed in pregnancy, and it becomes, if you have a patient who needs anticoagulation in pregnancy, that's when you need to enroll in specialist cardiac pregnancy services. And this is the clover that warfarin is made from, and it's still a good option in some patients, so we shouldn't throw it out completely. Thank you very much.
Thank you very much, Joe. Any questions? Yes.
A lot of patients actually self-medicate with antacids. You know, they'll buy them over the counter. Half the time the patient's coming, I'm actually a nurse, they're coming to hospital and, you know, it hasn't been prescribed. So where does that come into use of the NOACs?
Yeah.
That's all it does.
So the antacids are interesting. Looking at the data, it's probably all right to take an antacid. The only one, there's some caution about dabigatran if you have severe dyspepsia, severe acid problems, it can alter absorption, and actually just dabigatran itself can cause some dyspepsia, so I tend not to use that on people with dyspepsia. I think if you have a patient on long-term anticoagulation who has really good symptoms of dyspepsia, I tend to actually think about referring them for a scope just to make sure they haven't got an ulcer, because it's a higher risk of GI bleeding. So I don't think it's a major issue, but it's something I always ask them about, because it does affect whether you need to look further. You're going to investigate them more because they're more likely to have a bleed. But in terms of absorption, it's probably not a problem, but I tend to avoid dabigatran in those patients.
Joe, can you tell us your experience with rapid loading and PICSpan for cardioversions? Is that something you use? Or?
Yeah, so the great thing about the NOACs is you can start them on the anticoagulant, do a TOE, and then cardiovert them a few hours later. I have to say I'm not a fan of emergency cardioversion. I think emergency cardioversion is almost always a bad idea unless the patients are resting in front of you, because if you always cardiovert a patient every time they come to A&E, you never know how they're going to manage with rate control. You never know whether they're paroxysmal or persistent. So in general, I like to rate control people and bring them back a month later for a cardioversion. Very occasionally you have a patient who you have to cardiovert for some reason, and then we just tend to give them a decent dose of the PIC, normal dose of the Pixaban, a bit of heparin, and do the cardioversion after the TOE.
I see quite a common scenario is somebody who's allergic to penicillin who has a lower respiratory tract infection, and you want to give them clarithromycin for 5 days. I would say a lot of the diabetic patients, hypertension patients, would fall into that at some point in the time they're on the NOAC. So would that be an issue, do you think?
Again, this is where it gets difficult. If you've got a patient who's otherwise very well, is not at a high risk of bleeding, does not have a poor renal function, is not 90, then probably not, you're probably fine. But if you've got an 85-year-old who's 59 kilograms and has a low GFR, then you might think, actually, I'm just going to, here, I think I've got them here. I'm just going to come off. I probably, if they're on edoxaban, I'd be more worried than the others.
Would you potentially stop it?
I might do.
Yeah,
It's always difficult because obviously you're actually at higher risk of having a stroke when you've got a chest infection because you've got a higher thrombotic risk. So it's a balance. But certainly if I had a very high risk patient, I might stop it, particularly if they're on edoxaban. Or I might say, why don't you take a lower dose of edoxaban, take the 30 rather than the 60 for a few days, and then increase it. And the same goes for the other. Drop the apixaban or the rivaroxaban down to the lower dose. Apixaban and edoxaban are the ones with the biggest interaction.
I have really two questions. Number one, the people who have that really successful ablation therapy, do you need to continue the patient? The second one is that, which is most commonly related to the general practice. In the elderly people who are antibiotics, but they do have a recurrent bleeding, alcoholic anemia, HbA1c, and the GP is in a very difficult situation what to do. So in this kind of situation, do you have to refer this patient for the ablation in case, or we have to stop the medication?
So there are two questions there. I'll answer them very briefly. The first is, if you have an ablation, what do you need to do about anticoagulation? Now, I never do an ablation so someone can come off anticoagulation. If you look at the data, ablation is a really poor treatment. It's a great symptomatic treatment, but interestingly, after you've had an ablation, you're much more likely not to notice your AF, even if you have it. And if I cut your heart out with scissors and put a new one in, that's the best way I can isolate your pulmonary veins. We do that when we do a heart transplant. But if you look 10 to 15, 20 years later, even some of them have reconnected their pulmonary veins. And so I feel very anxious. I would never advise stopping anticoagulation after an ablation. The really difficult group, what happens if I do an ablation on someone who's aged 40? What do I tell them to do when they get to 65? Certainly if they ever have a stroke, they should be anticoagulated. I think this is going to be a massive problem for us in 10, 20, 30 years' time. And this is one of my real worries about people who ablate asymptomatic AF. Because then you're converting somebody who knows they've got AF and needs to have anticoagulation into somebody who thinks they don't have AF and they're never going to know when they have it. So ablation and anticoagulation are completely separate issues. If you have a transplant score, 2 and above definitely, 1 and above probably, unless it's just single female. Elderly patients with bleeding and anemia are a really difficult area. My personal advice is I think anybody who you're not going to anticoagulate for AF needs to see a specialist. Either because they're very young and they've got AF and you want to think, should we do something about it, or because they're very high risk for a stroke, and there are a number of options. There is the option of a left atrial appendage occlusion device. I think that's particularly useful in people who have recurrent GI bleeds, but remember there's absolutely no evidence in that group. All the evidence of left atrial appendage occlusion devices is in people who could take warfarin. But there is funding now in Britain for high-risk groups like those who have recurrent GI bleeds. If they've had an intracranial bleed, there are actually some trials ongoing. People who had intracranial bleed on warfarin, starting them on the NOACs because they have a much lower risk of intracranial bleeding. So I think they do need detailed discussion. Depends on the frailty of the patient. If the patient's nearing the end of their life, maybe it's not worth referring them up for extensive test and investigation. But if they're otherwise reasonably well, those are the patients I don't mind seeing in my clinics. Dr. Lencioni runs our appendage occlusion service here, Dr. Large up in Stoke. There's people around the country who can see them and advise. And sometimes the best thing to do is nothing. It's about weighing up the risks versus the benefits. Have they had a stroke before? If they have, they're much higher risk than if they're just 85 with no other risk factors.
Sorry.
Last question, and then we probably ought to move on to Dr. Foley, because we've best in mind.
If you're thinking about using a reversal agent, why would you use that particularly if there's such a short half-life? Because compared to warfarin and the reversal agent for that, would you need to?
So it's a very good question. It depends on the severity of the bleed. If you have an intracranial bleed, you want to reverse it straight away. There's no evidence it makes them live longer or do better, but theoretically we want to reverse it. If I, in the cath lab, rupture your pulmonary vein, and one thing to remember, AF ablation in the general population has a mortality of around 1 in 200 in smaller centres, up to 1 in 700, 800 in bigger centres. So it's not a completely safe procedure. Then you really want to reverse that within seconds because they're going for cardiac surgery. If you've got someone with a minor GI bleed, I wouldn't reverse it. I would just replace the blood and let it wear off in a few hours. It all depends on the severity of the bleed. Is the bleed in a critical site? In a spinal bleed you would treat, a skin bleed you might press. Are you having control? If you're not, then you can treat it. And most A&E departments are quite good about it because these drugs are so expensive that it blows your drug budget for the month for using one dose. Yeah, vitamin K is really good for reversing warfarin. The trouble with vitamin K is if you give too much, it takes ages to re-anticoagulate them. So don't rush in with 10, rush in with 1 or 2. But it does take a few hours. Again, Variplex is excellent if you've got a massive acute bleed. If it's a minor bleed or they've come in just with an INR of 8 or 9, small dose of vitamin K can get them back in the normal range. But if you're having to reverse it because of a high INR, then you need to think, should they be on a NOAC? There's something else going on. Thank you very much. I think we'll call it a day there. And I will now introduce my colleague, Dr. Paul Foley. He's an expert device implanter. Used to work together down in the Oxford region. He's now mainly based in Swindon. Paul.
Thank you very much. I am conscious I'm eating into everyone's lunchtime, if you'll excuse the pun. I appreciate there's a mixed audience, so I'm just going to go through quickly types of devices, looking at preventing problems and new techniques to do that, leadless pacing, subcutaneous defibrillators. I mentioned about the antibiotic pouch. I was going to discuss about delaying therapy with defibrillators to improve outcomes, but I think we'll just skip over that. And lastly, I'll just talk about a new technique, trying to use the natural conducting system to pace the heart to improve outcomes. So as you're probably all aware, we talked already this morning about implantable loop recorders. Pacemakers can be single chamber, so traditionally you put a lead in the right ventricle. The lead is often the cause of problems, and the can, so that is often the area where people have problems, infections and thrombosis. So the way possibly around that is for selected patients, the leadless pacemaker. Dual chamber pacemakers, everyone's familiar with, and cardiac resynchronization pacemakers. And defibrillators can either be transvenous, but the concern about that is always the lead. So a newer technique is a subcutaneous device, which avoids the complications of the leads. And of course there are cardiac resynchronization defibrillators which have to be transvenous. So pacemakers, they used obviously to treat slow heart rates, And they can be used, say, cardiac resynchronization pacemakers used to treat heart failure. And someone with complete heart block with slow heart rate, that will treat heart failure. But you've got to be careful that pacing the right ventricle can cause heart failure. And you may see this in your practice, people who've had pacemakers and become breathless. And that's because can be as a result of deterioration in heart function. So I'm just going to show you this. It's unfortunately embedded video doesn't want to play. So hopefully it will play. So it's just a schematic.
Conventional pacemaker, but it has no electrical leads, and it is implanted directly into the right ventricle without surgery by a catheter-based approach. The device is less than 5 centimeters long, weighs 2 grams, and has a volume of 1 cubic centimeter. The leadless pacemaker is mounted on a delivery catheter and covered with a protective sheath as it is advanced from the access site in the femoral vein into the right atrium. The pacemaker can be directed from the right atrium across the tricuspid valve and into the right ventricle with a deflection controller that is a component of the delivery system. The protective sheath is then drawn back and the pacemaker advanced until it makes contact with the right ventricular apical myocardium. A coiled spring on the distal end of the pacemaker makes fixation to the myocardium possible. The device is rotated through 1 1/4 turns to screw it into the right ventricular myocardium. The pacemaker contains a radiopaque arrow that can be seen under fluoroscopy and used to guide the rotation of the pacemaker. The delivery catheter is then detached from the proximal end of the pacemaker. The tethering wires are disconnected and the delivery catheter is withdrawn. The pacemaker can be programmed and interrogated externally like a conventional pacemaker.
So that's a useful technique for selecting patients. I mean, only about 10% of the devices we implant are single chamber, so not every patient is suitable for that. So it's not it's not for everybody. But for people at high risk infection or who only occasionally use the pacemaker, it could be useful. Now moving on. Just going to show you the subcutaneous defibrillator, and so this is the advantage of this is you have no leads in skin, and so everything is outside. So it's a fairly surgical procedure in that make an incision with the box placed behind the heart, and then the lead is tunneled alongside the sternum, and involves 3 incisions. It's normally done under general anaesthetic just because the device is routinely tested, i.e. patients put into ventricular fibrillation before you finish the procedure and check if it works in a satisfactory way. And the advantage is there are no leads within the body, so you don't get any problems of subclavian thrombosis or the leads wearing out, because obviously a defibrillator lead is quite thick and there's quite a lot of movement in the heart. And so over time defibrillator leads can fail, and they tend to be the weak points, whereas with this system there's very limited movement. The disadvantage to this system is that it can't at present deliver anti-tachycardia pacing. So a lot of patients who go into ventricular tachycardia can be treated with pacing the heart out of ventricular tachycardia, which avoids the need for shocks. So again, that's useful. So it's particularly used in, say, those patients, young people who's likely to have major problems with ventricular fibrillation, such as Brugada and non-QT. And for selected patients who you think are at high risk, so patients who have ischemic heart disease and poor left ventricular function, who you think are likely to have ventricular tachyarrhythmias, but have never had them. And at present, that's the major group of people who are getting them. So hopefully this will move on. One of the major problems we have is as people get older and the more devices put in, patients can get problems with it. One of the major concerns is infection. So one way to reduce that beyond good surgical technique is to use an antibiotic pouch. And we know about 1 to 4% of patients who have a defibrillator or pacemaker or cardiac resynchronization device will get infected. And we know between a quarter and 50% of those patients are judged to be at high risk. And the worry about that is the mortality, which is half at 3 years. And it's very expensive because you've got to take the old device out, often long-course antibiotics, they made it a temporary system, and then you put a new one in, and these devices aren't cheap. And so not only is it, there's a high risk of mortality for the patient, there's also, it's very expensive. And so the antibiotic patch can reduce this risk by about 75%. And so what we know is patients getting older, you see this in your practices, they're getting more comorbidities. The procedures go on for longer because we're putting more complex devices in. And often, as I said, some patients will develop heart failure with dual chamber pacemaker. And so we'll upgrade it, so we'll go back into that pocket and put additional leads in. And that puts the patient at risk. And some of the bacteria are becoming more resistant to common antimicrobials. And this is a patient you can see here where the pacemaker is eroding through, and that's the lead which has been sewed down. And that's, that feels, if you see that, that's a very disappointing result. I think that's fair to say. Infection prevention is inconsistent, and we use the same thing for everybody. We don't target currently what we do to reduce this infection. And it currently is intravenous antibiotics about an hour before the procedure starts. And then in the States particularly, irrigated pocket antibiotics. And then some patients have oral and some patients have intravenous antibiotics afterwards. But if you look at those patients, if you have an infection, no matter what type of device you have, this is 200,000 patients in the United States, your mortality is significantly increased if you develop an infection, no matter what type of device. And so the idea of this antibiotic patch is it can stabilise the box so it doesn't move. It's over, starting 2 hours after it goes in, and for a minimum of 7 days, it elutes 2 antibiotics, minocycline and rifampicin, and then the mesh sort of reabsorbs. And these are just some pictures of the mesh at 1 day, presumably from a pig model, then 7 days, and then 5 weeks where it's gone. And so it's very good, and it's been shown to reduce the risk of infection. And we know that there's certain patients at very high risk of infection. So there's certain procedures, certain medications, and characteristics increase the risk of infection. And so things like going back in, this leads moved, that increased the risk of infection by 15 times. There are some patients you can't avoid that risk, so they're dialysis dependent or got renal failure. So those patients you might use the mesh or possibly consider a leadless pacemaker if they're suitable. I'll just mention about, this is a patient goes into ventricular fibrillation, and then you'll see the shock coming from the coil to the can and going back to the science room. Traditionally, we've been quite cautious about how we program defibrillators, but over the last few years, we've become much more lenient, and so we often let the patient, depending on the speed the heart is going at, stay in their ventricular rhythm for longer, because often it will sort itself out. And in fact, shocks increase mortality. So this is just one of a number of studies looking at the risk of a patient who's these groups of patients. So in the black, they've never had any ventricular arrhythmias. In the red, they've had shocks, and the green line is those patients who've had antitachycardia pacing, where the device paces the heart at a faster rate and stops the ventricular tachycardia. And what you see is if you have VT and can stop it antitachycardia pacing, you actually do as well as somebody who's not had any therapy, according to this study. But if you have shocks are bad news. So we're now programming devices to minimise the risk of shocks. And that, the advantage of that is that not only do you minimise the risk of shocks for rhythms that need treatment, but also there's always a risk of any of these sensitive devices that they can treat other rhythms like atrial fibrillation, which don't need shocks. but they can get shocks. And for young people, it's terrible. They go out running or something else to get their heart rate up and get an inappropriate shock. The psychological morbidity of that is very high. So this is just some strategies we're using routinely now to reduce the risk of shocks. So I'll just skip over that in interest of time. Now the last thing, so I know it is lunchtime, is left bundle pacing, His bundle pacing. So the bundle of His lies below the AV node, and so you can put a lead directly onto the His bundle. And traditionally we've always placed leads in the right ventricle. But what we know is that there's a risk of heart failure of conventional right ventricular based pacing. So this is patients who are getting, the top is those where they're getting more or less than 40%, and the bottom is more or less than 80% right ventricular pacing. And that's the risk of getting heart failure, which is significantly increased the more you get right ventricular pacing. Now you might say, okay, that's fine, we just take those patients who are high risk, so those patients who've got ejection fraction less than 50%, and we'll give them a biventricular cardiac resynchronization pacemaker, so we'll pace the right and the left, and that'll make everything all right. But unfortunately, that's not quite the case, and in this study, there was no benefit to that strategy. And we know right ventricular pacing is life-saving, so if you've got complete heart block or asystole, that's what you want straight away. But it can cause problems. So the leads can damage the tricuspid valve, making a tricuspid regurgitation. The leads, unfortunately, can migrate through the wall of the heart. Here you see a cardiac surgery, a lead sticking outside the heart, and the leads can move. And so it's not perfect. And this is a patient who's who's receiving right ventricular pacing, and you can see that very broad QRS, and that means there's a long delay in the ventricle being activated, and that's not natural. That's not what you're born with. So you can see potentially why that could cause problems. And so to get around that, we're currently programming all our pacemakers to reduce the amount of right ventricular pacing patients get. But there's always a trade-off, and the trade-off is that the time for the PR interval has to be prolonged to do that, and that can cause problems in itself. So His bundle pacing is where you target the His bundle, and then you get a normal ECG. You only have a right atrial lead, so it doesn't go through the right ventricle, and you can get synchrony between the atrium and the ventricles. And if this is a model, just taking a patient who needs a pacemaker. So at the top is their narrow QRS. If you give them a RV pacing, you get very broad QRS. If you give them bivent pacing, you get a better QRS, but still quite broad. And if you give them His bundle pacing, you replicate normal physiology, so you get exactly the same as you were born with. And this is some evidence looking at the benefit. This is a site in the United States showing that if you have His bundle pacing, you're much less likely to get heart failure and much less likely to die. And this is a schematic. At the top is looking at the right ventricle, the bottom is the left ventricle, and starting from the left is what you're born with, so you can see nice homogeneous activation at the bottom of the left ventricle. If you His bundle pace, you can either directly pace or pace nearby, you get exactly the same. But if you bivent pace, you get quite disorganized activation of the heart. So His bundle pacing could be better than bivent pacing potentially. And this is just a couple of examples before we finish when you have lunch. This 85-year-old gentleman had 2 admissions syncope, had first degree AV block in daytime, went back. So he's got such long PR intervals. If we put a conventional dual chamber pacemaker in, he'd like to get pacing. And here you can see he gets a nice narrow QRS, almost like normal. This is another chap who had moderate left ventricular impairment, was missing complete heart block in another hospital, and had a cardiac synchronization pacemaker put in. And unfortunately, it wasn't possible to pace the heart very well with the lead, just because of his anatomy. And so he had His bundle pacemaker put in, and this reversed the left bundle branch block he presented with. So His bundle pacing was actually first described in 1970 It does is becoming very popular. It's got the beauty of basic electrophysiology, the elegance of simplicity, the parsimony of cost-conscious care, and the joy of helping people. And this is just one example. On the right is right ventricle pacing, on the left is his bundle pacing, and which would you rather have? Now, moving on, so you can't always get his bundle, or there can be problems with his bundle pacing in some patients. So another technique that's coming on stream, and I'll just mention it briefly, is pacing the left bundle directly. So just below the his bundle is the left bundle, and you can insert a lead into the left bundle directly. And you can see on the echo, this is a cross-section through the left ventricle. The left ventricle is indicated here. And there's the lead directly into the septum. And that's very popular in China, and no big trials, but again, that can be useful in certain patients. So, in conclusion, there's some new techniques. We're programming defibrillators better. We're trying to reduce infection with antibiotic pouch, and physiological pacing appears very promising, but we do need randomised trials to show the benefit. Thank you very much for your attention.
Thank you very much, Paul. We've got a couple of minutes before we're going to stop for lunch. Does anyone have a question they want to ask? If not, perhaps I can ask by saying that when I observe my colleagues doing his bundle pacing, it seems to take them about a couple of hours, whereas a straightforward VVI pacemaker takes about 20 minutes. Is that going to change, or is it always going to be as tricky?
I think it can be very, very straightforward. I think there are patients where it's more difficult. I think tools will get better. I think the technology will improve, and certainly for the majority it's not that much longer now. But there is always a benefit, if you can do a rush job or a proper job, but you can't do both. And so, I kind of think sometimes you do need to spend the time, like you do with an AF ablation. You need to do it properly, otherwise you still not coming back.
Sorry, with the leadless pacing, isn't it not a risk that it will migrate somewhere?
That's a very good point. So there were two devices. There's only one on the market at present. One of the devices got pulled because of problems with it could potentially migrate, but in fact it hasn't been a major problem. You do give it a little tug when it's put in, and they seem to stay there.
And I suppose you just unscrew it then if you need to change it.
Well, that is the theory. So there are two theories behind that.
That's the worry for me.
There are two theories. One is you ask someone like Joe to come pull it out for you, or the other is that, like space dust, you just put another one in. So it depends what age the patient is. I mean, they're supposed to last 10 to 15 years. And there are cases where they have pulled it out, and it's been fine.
So I think we should have one more question. Over there, sir.
If you're right ventricular pacing, you've got a left bundle branch block pattern. Does left bundle branch block without pacing cause heart failure?
Absolutely, yes. So that's a very good question. So one of the common indications for cardiac resynchronization pacing is patients with poor left ventricular function, left bundle, and they're the ones who do best. So left bundle in itself can cause heart failure.
Brilliant. Well, thank you very much for a fantastic session. Lunch is going to be in the main area. After lunch, we aim to restart at 1:15, and we've got a parallel session for the first, and then we'll rejoin together for the last session with some state-of-the-art talks about the future.
So do we come
Thank
back?
you very much.
Do we come back? Yeah.